is Amanda Nello. I'll be introducing you to the course today for medication-assisted treatment for opioid use disorder. We'll give some more attendees a few more minutes to join the course, and then we'll jump right in. Is Amanda Nello. If you are already introducing you to the course today for medication-assisted treatment for opioid use disorder, please go ahead and sign in on the chat box. And what you'll do is enter your full name, your designation, and then please include your email address so that we can send you the CME or CE evaluation form at the end of the course. A few more minutes to join the course, and that's what's going to qualify you to receive those units. Okay, so I see we have 22 participants and about 12 people and 13, 14 signing in, so that's great. Please be sure to sign in the chat box and include your full name, your designation, and your email address. And what we'll do at the end of the course is we'll send you the evaluation form for CME or CE credit. And for that evaluation form, in order to receive the credit, you'll want to return the evaluation form back to us, and then we'll give you a certificate of completion so that you're able to self-report. So I'll give one more minute or so, and then we'll get started. Okay, welcome everybody. I'm going to back up the slide one bit. Today we are going to present on medication-assisted treatment for opioid use disorder, and CME and CE credit is available for self-reporting, so be sure to follow the instructions on the next slide in order to qualify to get those credits. You want to make sure that you sign in the chat box if you haven't done so already. Please include your full name, your designation, and your email address. And then if you're looking for CME or CE credit. And what we'll do is we'll email you an evaluation form after the course. And then once you return that completed evaluation form back to us, we'll provide you with a completed certificate of completion. Okay. And then if you have any questions that come up during the course or during the presenters speaking, feel free to send those through the chat box, and then we'll save them for the end of the course. And we'll also have an interactive discussion if you guys would like, if you have anything you'd like to ask the experts in the area. So today from Sion Clinical Corporation, we have Dr. Anish Shah and Dr. Rani Badair presenting. And like I said, we have CME and CE credit that is available for self-reporting through this course. And I'm going to go ahead and hand it over to Dr. Anish Shah, and he's going to begin his presentation on the opioid epidemic.
Thank you, Amanda, for the introduction. I'm Dr. Anish Shah. I'm a psychiatrist and CEO for Sion Clinical. And today I would be speaking about the opioid epidemic, biological treatment of medication-assisted treatments, a subtle difference between the choices of treatment that we have currently, and then also talk about the long-term efficacy and safety data of this treatment. Before I start my presentation, I would like to start, since this is a CME activity, I need to come up with that disclosure. I do not have any interest with any pharmaceutical company. I don't represent or serve as a speakers. I do have some stocks and options through some mutual funds that I have vested in retirement through various companies. This event is sponsored by Sion Clinical Research in collaboration with Sion Clinical Corporations, and we have not used any other external fund for this presentation. So my first topic is the opioid epidemic, and how did we get here? And let's talk about how the opiate epidemic was evolved. So going back to the history, in late 1990s, pharmaceutical companies reassured the medical communities that patients would not become addicted if you are prescribing opioid for the pain as a pain reliever. Healthcare providers were told that pain is an important vital sign, maybe the fifth vital signs. It is important to treat it. And even if you use opioid for a long term, patients do not get addicted. What happened from that is the increased prescription of opioid medication that led to widespread misuse of both prescription and non-prescription opiate before it became very clear to all of us that this medication could indeed be highly addictive. We started learning about the data early 2000, and since that we have a progressive increased issue with opioids. Just to tell you, in state of California, we had 2,311 deaths related to any opioid overdose in 2018. Fentanyl has been progressively been a worse enemy to our patients, our loved ones, and there are progressively increased emergency room visits, and the prescription opiate have also increased exponentially till at least the 2019 data that we have. Now, if you look at opioid epidemic nationwide, 130 every single day from overdose related to opioid drugs. These are way too many people, in my opinion. If you look at about 11.4 million people misused opiate, and these are the HSS data for 2018, which were published in 2019 January. And about 2 million people misuse prescription opiate for the first time in their life. So which is quite a high number of people now misusing opioid. And these are again national data. And we had about 28,466 deaths attributed to overdose from synthetic opiate other than methadone. And we of course have a lot of issue with heroin as well. And we lost about 15,482 people to deaths attributed to overdosing heroin. So these are quite a alarming national statistics that you see currently for opiate epidemic. Now, if you look at issues in California, about 5.8% of our subpopulations misuse opioid. In about 2,000 people died of opioid in 2000. If you look at OUD and also people who are looking for their help, we have about 200,000 to 245,000 people with OUD and have no access to opioid agonist treatment in state of California. Now let's look at the issue in our Northern California counties, Lake, Mendocino, Sonoma, and Marin County. If you look at our statistics, then opioid epidemic in Northern California is even much more greater than entire state, as we have 11 per 100,000 opiate-related deaths in state of California. If you look at Lake County, it's number 5 in the entire country in terms of opiate-related deaths when it comes to per capita population. Mendocino County, 2 deaths every month from opioid overdose. And in Sonoma County, a resident dies of opioid overdose every 8 days. Now, this is also a slide that shows up about how the opiate epidemic has evolved. And this is from 1965 to 2000. And if you look at all different illicit substances that have been abused by our patients, you can see there is exponential rise of let's say, pain reliever from 1990 onwards. Now, this is an overall statistics of opiate use, and you can see that marijuana is, overall statistics of substance use disorder in US. As you can see, marijuana is probably number 1, and number 2 lies here is the pain reliever. So the pain pills are probably the number 2 amongst all other substances that we use. The 3rd is cocaine, 4th is heroin, and last is sedative and hypnotics. Now, this is also an interesting data that I wanted to point out here. Now, if you look at the statistics about how patients receive opiates, so there are 2 categories here which really strikes out. One is opiates that were given or brought in or took from a friend and relative. And that are about 53.7% of the patient population have these issues. And then if you look at prescription from physicians or a doctor, then those are about 34% subpopulations who get opiate from physicians. So by and large, in our community, we still have majority of people who are obtaining opioids from the friends or relative, and most of them are getting at no cost. They are getting free. And those are about 40.5% of the subpopulation, as you can see here in this slide. And then if you look at the people who got the patients who got the substances from drug dealer or obtain it through an illicit means, then there are far less than 4.9% of the patient who actually received it from a drug dealer or from some other ways, you know. So once again, these are the two major categories: prescription from doctors and physicians, and prescription from or not prescription, but given by or brought in by or took it from friends and relatives are the two major categories how our patients are receiving opiates currently. Now, this is also an important slide to kind of gaze some perspective about what is substance use disorder. And some of the symptoms that I'm describing here probably applies to over the board on various substances. For example, the same criteria applies for opiate use or a cocaine use or an alcohol use. And if you see these warning signs, and probably you or your loved one probably may have substance use disorder. So this is a good screening to look into when you are looking at diagnosing or judging or thinking about substance use disorder for yourself or your loved one. They always use excessive amount of time in using and obtaining illicit substance. They also spend, people with substance use disorder also spend excessive amount of money. They all have a tolerance or withdrawal symptoms, meaning that they need to take more and more substance to get the same high or effect, or when they don't use it, they have an acute precipitous withdrawal symptoms. They keep using it despite of knowing that it is hazardous to their health, their major obligation at work or in relationship, or if it interferes with their daily social activities or causing other personal problem. They, however, continue to use it. There's also a significant craving or urges to use illicit substances, and they also have unsuccessful attempts to cut down. So when somebody is showing this sets of signs and symptoms, then we should suspect illicit substance use disorder. Now, the next question is, what is medication-assisted treatment? Medication-assisted treatment is the use of medication in combination with counseling and behavioral therapies, which is effective in treatment of opiate use disorder, and that can help some people to sustain recovery. So basically, MAT is where you use a bunch of medications which are evidence-based in conjunction with counseling, behavioral therapies, and that just makes the core evidence-based MAT treatment. Now, if you look at the medications, then there are three major medications which has been approved for opiate use disorder. So the first is obviously the buprenorphine. And if you look at buprenorphine, then you will have three major medications that have been used for opiate dependence under that subcategory. One is Suboxone, which is buprenorphine and naloxone. It comes into sublingual film and tablet. The second is Sublocade, which is an injection, which patients get it once a month, and it has an extended release buprenorphine in it, and then Subutex, which is just buprenorphine without naloxone, and it comes in a sublingual tablet form. And the last is Zublau, which is buprenorphine and naloxone, which also is in a sublingual tablet form. The second one is methadone. It's also been FDA approved for opiate dependence treatment. And last set of medications are naltrexone and Vivitrol. And naltrexone is generally an oral tablet, and Vivitrol is an extended release injectable naltrexone, which is given intramuscularly once a month. So naltrexone has oral tablets and also injectable forms and so forth. And now, when you treat opiate dependence, then having an evidence-based treatment approach and having a practice or a program that is based on evidence-based practice is key. When we said EBP-based program, it should have three components into this. First, it should have a research evidence. So the biological as well as psychosocial treatment that has been given through the program must have a research-backed evidence. The clinicians who work in that program must have clinical expertise to manage opiate dependence issues. And the treatment staff should also take into consideration patients' values and circumstances. When you have a combination of all these positive factors built into a program, that's what is I consider as the EBP programs, which is evidence-based and has the most efficacy in helping patients with opiate use disorders. So all these three components in a treatment program are essential part. Now, before I go into the medication and explain how it works, I would like to go through some basic understanding about how various opiate medications work on receptors. And there are three categories of biological treatment modalities. One is opiate agonist, second is opiate antagonist, and third one is partial agonist and antagonist. Now, if you look at opioid agonists, these are the medications who activate the opiate receptors in the brain in full capacity, and it gives you the full opiate effect on all opiate receptors. And these medications are heroin, oxycodone, methadone, hydrocodone, morphine, opium. So these are called as opiate agonists, which works on all receptors fully in your brain. And if you look at the second medications categories, these are the opiate antagonists. And under two, we have two categories. One is naltrexone and another one is naloxone. And opiate antagonists are the drugs that block opiates by attaching to the opioid receptors without activating them. So basically they sit on the opioid receptors, but they don't activate them. And hence antagonists cause no opiate effect, but it blocks full agonist opioid. So basically when the antagonist is sitting on opiate receptors, when patients are using that, they cannot get high or they cannot have the full impact of opiate medications or illicit substances when their patients are using that. And so again, under these two categories, there are true medications. One is naltrexone and naloxone. And I'd like to talk a little bit about difference between naltrexone and naloxone. First of all, naloxone is a fast and short-acting medication that is only generally used in an emergency treatment for patients who use overdose. So the way it works, it knocks off quickly the opiates from the brain receptors, and thus it reverts to deadly effects of opiate overdose, by decreasing the heart rate and respiratory depressions. So opiates, when somebody overdose, there are two reasons why most people would die. One is from respiratory depression, and the other one would be from their heart failing and their heart rate going down. So naloxone is helpful in displacing opiates from the brain receptor, and hence the reverse the bradycardia or decreased heart rate and also respiratory depression. So it's a life-saving medication and is generally been used by EMT or in emergency room or in a serious manners. Generally, naloxone is given uh, in 2 doses. Mostly you give a 1 dose, and if somebody doesn't uh, have a good outcome from the first injection, then you can use in 30 to 60 minutes another dose. And the second one that I want to talk here is the naltrexone. Naltrexone is also opioid antagonist. However, it kind of works a little slowly, and it is more efficacious to patients who have stopped using opiates and those who have cravings. So naltrexone when it's used as somebody has to be off of opiates for about 7 to 10 days. And when they use naltrexone, then they have a reduced craving, and they also are not likely to experience high if they use opiates and so forth. Now, the third category is partial agonist and antagonist, and buprenorphine is a partial agonist, meaning it activates the opiate receptors in the brain to a much lesser degree than a full agonist. So it kind of causes a ceiling effect, and I'll explain you what the ceiling effect is. So it kind of used as an agonist, so it does give some effect that a lot of the opiates have it, but it kind of limits to an extent by creating a ceiling effect. And buprenorphine also acts as an antagonist, meaning it blocks other opioids while allowing for some opiate effects of its own to suppress the withdrawal symptoms and cravings. So the agonist effect of buprenorphine helps with the withdrawal symptoms and craving, and antagonist kind of prevents somebody when they use other opiates to get that high or detrimental effects such as respiratory depression and also bradycardia or reduced heart rates. So that is how the buprenorphine works. Okay, now next slide is for how buprenorphine or Suboxone works. So buprenorphine is an agonist and partial agonist and an antagonist. So when somebody uses, for example, full agonist or opiate agonist, then what they experience is analgesia, euphoria, constipation, respiratory depression. And this is when people use opiates like oxycodone, hydrocodone, heroin. Now, what buprenorphine does is it limits the effect of, it limits by its partial agonist. And that's where let me show you. And this slide points out toward the ceiling effect it has. So basically what it does is it limits the respiratory depression, and it also limits the euphoric effect, and patient can also limit intake. So if you keep using buprenorphine, then you might not get the high that you will get it from other medication, and it doesn't cause detrimental issue like respiratory depression or also severe effect on your heart. And the other thing is buprenorphine also has a very high affinity for opiate receptors, like I said. So when heroin or other medications such as oxycodone or fentanyl or any other strong opiate medications patients try to take, they are not able to get that high because buprenorphine is sitting very tight on those receptors. and so forth. Now, there is caveat when you use buprenorphine, and I think one should be mindful about the ceiling effect sometimes that have. Then if you give buprenorphine to a patient who already are actively using other opiates, then sometimes they have a precipitated withdrawal. And that is one of the aspects that happens with buprenorphine use, now there are four core treatment options with buprenorphine. One is, biological treatment options for opiate dependence. One is obviously Suboxone, which comes in film and tablet. So to summarize, it suppresses and reduces cravings. It also helps with the withdrawal symptoms. Naltrexone, it comes into tablet. It blocks the euphoric and sedative effect of the opiates. Vivitrol, which is a naltrexone injections, which you need to take once a month. It blocks the euphoric and sedative effect of opiate, and it also prevents feeling of euphoria. And most of the patients we see in our practice also have comorbid psychiatric disorder. And when they have a comorbid psychiatric disorder, it is also absolutely very important to treat post-traumatic stress disorder, clinical depression, anxiety, bipolar disorder, or whatever you see as a comorbidity. Now, I get asked all the time that whether naltrexone injection or oral tablets, what's the difference? What are the data along these two treatment modalities? There is a study that was done in 2006, and I think with naltrexone injections, patients have fared significantly better in terms of having a lower craving for opiates, less opiate use, or better treatment retention. So those are the three things which has been far superior as compared to placebo with naltrexone injections. People who use naltrexone injections are also less likely to relapse and have a longer period of opiate-free days compared to when you use oral tablets. Next one is MAT treatment choice. So I think this is a very, very important topic that a provider or clinician should keep in mind and have to have an open mind in discussing with their patients while offering the correct treatment or appropriate treatment that works for patients and their clinical status. One should look at all other psychiatric comorbidities. One should assess for suicidality, psychosis, if they have other uncontrolled medical problems, if they have dependence on other substances, those also should be looked into. And then one should also look at chronicity of the problem, severity of the problem, and also involve patients and the family members in shared decision making. Then one should talk about residential program versus office-based treatment versus OTP or outpatient treatment protocols. One should also talk about risk of treatment without medication. You should also talk about how the psychotherapy or counseling alone may or may not work based on the clinical status of an individual. So there should be a comprehensive discussion around various treatment modalities and options. And biological providers should also give and explain differences between methadone and buprenorphine, naltrexone, and also discuss various pros and cons, side effects, treatment initiation requirement, duration of treatment, treatment dropout, and termination related issues, because that will also help make an informed decision. When available and appropriate, the final discussion must involve also a family member or a significant other, because they are going to be very important in patient success story and the work that you will be doing with the patient. Now, this is the difference between choosing opioid agonist versus antagonist for office-based treatment. Like I said, agonist is going to be medication like buprenorphine or Suboxone, which is partial agonist, and antagonist, as I have explained. And antagonist medications are oral and injectable, naltrexone, as we spoke. And I think they both work, but if you're looking to manage physiological dependence or withdrawal on stopping, then agonists are probably better. Reinforcing effects and promoting medication adherence, then you will see that buprenorphine has a superior data than antagonists like naltrexone. Um, it eliminates ongoing opiate use. I mean, if people are using Vivitrol shots or naltrexone tablets religiously, you are less likely to have people who are going to be experimenting with other substances because they will be concerned about withdrawal or side effects and so forth. And treatment dropouts also are reduced if you are using Vivitrol injections. Um, However, opiate-related side effects such as constipation, sexual dysfunction, and sweating is much less with buprenorphine. And overdose, when combined with sedative, the risk is even a little bit more with buprenorphine. And so, I mean, they both work. Like I said, the decision has to be a shared decision in consultation with patients and the family member to kind of choose what the best treatment option is for the patient. Now, getting somebody on a buprenorphine requires a preparation. It is an office-based treatment, and it is kind of seamless and easy to administer in an office settings. However, before you start buprenorphine treatment, certain things must be done. A clinician must do a history and physical examination. Please verify a list of all medication, all the other illicit substance and alcohol use that they may be doing. Uh, do a brief psychosocial assessment, do the lab testing. It is very important to sign informed consent and treatment agreements. Provide education to the patient about induction and how the induction looks like, how the stabilization phase look like, and how the maintenance process would look like for the patients. And advise patient not to use opiate for appropriate amount of time to prevent precipitated withdrawal. This is a very key issue. Patient must not use, if they're using short-acting opiates, must not use it for about 24 hours. And these are the medication like oxycodone. Please ask patient not to use any medication before using them for an induction. Use it for 24 hours. Now, if they are using a longer acting opiates such as fentanyl or methadone, then they may need to be off of opiates for anywhere from 36 hours to 48 hours, sometime up to 4 or 5 days before you bring them in for an induction visits. And recommend that the patient gets a family or friend to drive them from home to the clinic during induction. You don't want to see a patient coming to your clinic with withdrawal and risk themselves with driving through the whole process. Now, when you are bringing patient for induction to your office and when you're administering the first dose, the first important thing you must notice is that they have to be on mild to moderate withdrawal. So that indicates that they have not taken any other opiates at least a day before they came in. And then you do clinical opiate withdrawal scales, and then you try to see what their cow scale looks like. And then you try to monitor them through the induction process. Now, one caveat about induction to keep in mind, if your patients are on methadone, then they must be tapered off to 30 milligram daily dose before you transfer into an opiate to the buprenorphine treatment. So if you are seeing, sometime in our clinic, we see patients who are on 90 milligram, 120 milligram methadone. buprenorphine treatment is not right treatment for them. So we recommend them to first slowly taper off the dose, and once they are on 30 milligram dose, we ask them to refrain from using any opiates for 96 hours, and then bring them for induction visits, and then we give them medications, buprenorphine. And this is going to be a very key strategy to have a successful induction and not have any precipitated withdrawal during your induction visit. So the standard induction protocol is on the day of the first day of induction, you give the first dose, and you must see that the patient has is in a withdrawal state at that time. So typically we give 4 milligram buprenorphine dose, observe patient for 1 to 2 hours, and then we again give second dose of about 4 milligram, and then we also manage and observe for withdrawal symptoms. And then some clinician will even go conservative. They start with 2 milligram dose. You can also do that. Your induction visit is going to be a little bit longer, but you must have about 2 to 4 hour period in your schedule to do inductions. Most patients will end up being around 12 milligram buprenorphine dose on day 1. Then you monitor patient on day 2, and during that time you also bring patient in, and then you can, for day 2, we have also done visits over the Zoom or over the phone, and then at that time you look for cravings, you look for withdrawal symptoms, you ask how patients are doing, and then you also give them other additional dose of buprenorphine, and then patient may go up on the dose if they have a withdrawal symptoms and have a significant craving. And most patients go up to 16, 18 milligram dose in the day 2. On the day 3, when you see patients, and if you see the patient is overly medicated, you can lower the dose. But if patient still has a problem, we have kept going up. And the maximum dose I recommend is 32 milligram a day. And there are very, very few patients that we have used such high dose. Doses higher than this will not harm the patient, but it will also not decrease patient's craving due to the ceiling effect, as I have explained with buprenorphine. And patients who require higher dose should be also reevaluated at the time of induction and to monitor for a diversion, Now I'm going to go through some data for Suboxone treatment or buprenorphine treatment. There are numerous data that points that buprenorphine treatment, when used long-term, has much better outcome in terms of patient psychosocial functions and also in terms of their sobriety status. Remember, addiction is a chronic illness, and the more long-term the problem is, it takes longer to also heal the problem through biological treatment or through psychotherapy and so forth. So the short-term buprenorphine treatment generally do not work for most patients who have opiate dependence issue for several years and so forth. Again, it's an underutilized treatment. It's a safe, it's efficacious, and when it's used with biopsychosocial treatment, really produces great results. Patients who use long-term Suboxone treatment are more likely to adhere to 12-step programs, self-help group, and they also have much better occupational stability over 18 to 42 months. So outcome for psychosocial data in terms of occupational is pretty good with long-term use. Moreover, if you look at other studies, it also shows about quality of life for patients and family members, both, and longer period of detoxification is achievable with long-term Suboxone treatment. And it's also very cost-effective. Long-term Suboxone treatment in multiple research have shown to save cost for patients, save cost, or have economical, more viable options for family members. And it also saves tons for various emergency room visit, hospitalizations, and other tertiary level care that our patients receive because of their opiate use disorder issues. So it's also a very cost-effective treatment overall for everyone. Now, this is, and I would end my presentation with some of the misconceptions people have about buprenorphine. The first misconception is Suboxone is just substitute to one drug for another. That's the biggest myth. Suboxone just substitute one other drug to other is not true. If you use as directed, buprenorphine and naloxone is a medication and not a substance. It is stable, safe, and long-acting medication with a ceiling effects, and it is prescribed for the specific effect of improving patients' physical and mental health and prevent HIV, hepatitis C, other infectious disease, and most importantly, death. You would hardly see patients dying who are on Suboxone, and Suboxone is a lifesaver. It prevents respiratory depression. It prevents severe impact on your heart if a patient is using high dose of opiates. So second myth that I wanted to also go through is Suboxone is a failure of willpower or giving up, and addiction is a medical disease and not a moral failure. So that's my few cents about when people judge or people speak about addiction as a failure of willpower, and taking medication for it is a sign of giving up. Actually, if you look at numerous neuroscience and neuropsychological data, addiction is a chronic illness due to various neurological malfunctions of your uh, of your brain, and that leads to the increase in cravings and other opiates and other addiction use. So it's a neuropsychological illness basically. So it's like any other disease that needs to be treated, and it should not be considered as a moral failure if you or your loved one is taking buprenorphine. And buprenorphine is incompatible with 12-step programs like Alcohol Anonymous and Narcotic Anonymous. Now this was a problem before, but now more and more 12-step groups are accepting patients who have had treatments with buprenorphine and other substances for their opiate use disorder. So the last misconception is about patient gets high or loaded on Suboxone and get intoxicated, which is also not very true. Intoxication with Suboxone is very rare. It usually do not occur if you're using in a right dose, and also when you're using along with a proper monitoring and so forth. Like I explained, Suboxone has a ceiling effect, so its euphoric effect is also kind of limiting. So it's very rare to see patients feeling loaded or high on Suboxone. In your clinical practice, if you see somebody high or loaded on Suboxone, then there is very good chance that the patient is also using other illicit substances like cocaine, benzodiazepines, marijuana, or severe alcohol, because those illicit substances would also augment the effect of buprenorphine. Moreover, if buprenorphine, when it's taken with stimulant like cocaine or amphetamines, then it is also cause the loaded effect or the high that you generally see in patients and so forth. The last misconception is patient will just sell Suboxone, and that is also not very true. Physician can monitor for diversion of Suboxone by instituting film or pill checks, or checking patients' urine for buprenorphine. Furthermore, diversion of medication is not unique to opioids or buprenorphine. The rate of diversion in our community is similar when you look at buprenorphine and compare that with antibiotics. There was a study that was done. Antibiotics also has 20% diversion, and buprenorphine also has had 20% diversion. And also the vast majority of diverted buprenorphine is used to self-treat addiction, to treat somebody using to treat their own addiction, rather than trying to sell it on the street or giving out to somebody else. So since we don't have an access to care that easily available, people also tend to buy Suboxone on the streets in many cases. And this is an approach to MAT for OUD. And if you look at this chart, this kind of gives you a broad idea about how the MAT is used for opiate use disorder. So non-pregnant adult with opiate use disorder who are physically dependent. If they're not, then addiction counseling, consider long-acting injectable naltrexone. If yes, then probably you should use for post-withdrawal long-acting naltrexone, and if that fails, then you use buprenorphine. If they are still actively using opioids, then buprenorphine may be a better choice than naltrexone, or because you probably need to be off of with naltrexone for about 10 days, and that is very difficult for a lot of our patients. And this, you follow these algorithms to kind of see what's going to work for patients, and then you monitor. And then as a clinician, you should be open about switching a treatment approach as you see your patient responding. So my mantra to all of you is, if you have a patient with opiate use disorder, please use different strategies, be patient with your patient, use different treatment approaches, see what's working, what's not working, and modify or adjust your treatment. Be open about that as you treat your patient. And then once again, it improves quality of life, it's safe, it's cost effective, it reduces the risk of overdose, and this is the biggest plus in using MHE treatment. It also increases treatment retention. If some of you who are doing psychotherapy or counseling, your likelihood of success is going to be much more with your patient is going to be much more if you use buprenorphine treatment along with psychotherapy. And then it also improves social functioning. It reduces the criminal activity. This is a very big thing. We still have, we have used jails and prisons for various substance-related legal problems. And if we have a treatment options available for this people with severe addiction issues, then there are multiple data which shows that the criminal activities also is reduced with treatment, and I'm a big advocate for treatment for that purpose also. And then it also reduces the infectious disease transmissions. If you use MAT in a right spirit and have a correct program, then you are likely to reduce HIV, hepatitis B, C in your patients using MAT for their opiate use disorder treatment. With this, I'm finishing my presentation. I'll take question at the end of our presentation in chat box. So please write your question in the chat box. And now I would like to invite Dr. Rani Budere to talk a little bit about the psychotherapy and other psychosocial treatment for addiction, opiate addiction.
Thank you, Dr. Shah, for that lovely introduction, and thank you all for being here with us today. As Dr. Shah mentioned, I'm Dr. Rani Budere. I'm a licensed clinical psychologist, and I'll be speaking to the mental health and behavioral interventions for treating opiate use disorder. So diving in, first and foremost, it's important to note that the most effective way to treat opiate use disorder is a multidisciplinary approach. And the importance of this is underscored by SAMHSA in terms of a collaboration of care. According to SAMHSA, under federal law, MAT patients receiving treatment for opiate treatment programs must receive counseling, which may include different forms of behavioral therapy. These services are required along with medical, vocational, educational, and other assessment and treatment services. Regardless of what setting MAT is provided in, it is more effective when counseling and other behavioral health therapies are included to provide patients with a whole person approach. So kind of continuing to elaborate on this multidisciplinary approach, what it entails is frequent and open communication between A, the medication provider, B, the substance use disorder counselor or case manager. And these persons are wonderful at focusing on relapse prevention, connecting patients with resources, linking them up to meetings and peer support. And I'm going to speak more to their role later. The multidisciplinary approach also involves C, the mental health specialist, and they can be useful in treating comorbid disorders or underlying issues that also impact the addiction. And then D, medical assistant or admin staff are essential in helping to schedule the patient, remind them of follow-ups, assist with U-talks. Together, working as a team helps inform A, diagnostic clarity, B, treatment planning, and C, treatment efficacy. Now, under substance use disorder counselor, there's different sorts of credentials one can have. Recently, they've added a MAT endorsement certificate that you can enroll and get some brief training and get that added to your credential to be a kind of a MAT specialist. So that's a new and exciting thing that's being offered. So to go into more depth of what a typical substance use disorder counseling session looks like, it all includes obtaining general updates, staying connected with patients, and finding out about recent events. It also involves assessing recent urges, cravings, or relapses. And particularly, many people in substance use disordered counseling have had their own addiction or recovery histories, in which case they're very valuable in sharing shared experiences regarding addiction. It also includes conducting routine assessments such as the GPRA and the QOL. The GPRA is a Government Performance and Results Act, which is administered at our agency at intake, 3-month, 6-month, and discharge. That gives us great data on how their life may be changing with MAT, what parts of their life aren't changing. We get to assess for use of other substances, criminal behaviors, and so forth. The quality of life questionnaire gives us a good sense of their progress in treatment. And it also is valuable to the patient in starting to see and conceptualize what areas of their life are improving and what areas of their life they may be stuck in. Part of SUD counseling also entails connecting patients to recovery support within the community. I know Dr. Shaw spoke to NA meetings. And overall, as he mentioned, there's a change in the culture of NA meetings, less stigma towards MAT, although there can be some still. There now is a new type of recovery support meeting called medication-assisted recovery support, MARA, and they offer kind of 12-step like meetings, but people who are on MAT medications, they offer them via Zoom, predominantly all over the US. So that's a new and exciting developing part of MAT treatment. The SUD counselor will also help to connect patients with community resources to improve stability in other life domains, including food, perhaps getting them linked up, signed up for general assistance or food stamps, housing, pointing them in the direction of housing assistance or helping to get them connected to get signed up for low-income housing if that's appropriate, legal assistance, and occupational and educational assistance if patients have certain career educational goals. Maybe they want to work on their GED or other areas of their life. The primary component of SUD counseling is relapse prevention. It's having open-ended discussions on what one can do to prevent a relapse. If they've had relapses in the past, really unpacking them to find out what somebody might be able to do differently. Also formulating very specific relapse prevention plans that include action steps, coping skills, contacts for recovery, and so forth. And another component is really looking at cravings and teaching patients how to urge surf or navigate through intense cravings. Before I move on, just want to note it says low battery. That's okay. Okay. All right. Okay. So another evidence-based intervention in treating opiate use disorders is contingency management. And this is a behavioral health intervention that uses therapeutically applied incentives and other reinforcements to increase target behaviors. A very common incentive is a measure is medication compliance. Some sample incentives and reinforcers include having a clean UTOX, meeting program criteria such as attending counseling. Here at CEON, we require patients to come in monthly for a UTOX. If there's any issues that may impact their eligibility for a refill or how much meds we refill at any given time. For things like completing our QOL questionnaire, our quality of life questionnaire, we may often give out vouchers, Amazon or Starbucks. And contingency management overall needs to be tailored to patient needs and defined clearly for each patient and implemented consistently. The efficacy of contingency management has been found in the research and various meta-analyses when they look at contingency management with medication and then just medication alone. Another evidence-based intervention for opioid use disorder is cognitive behavioral therapy, also known as CBT. The goal of CBT is to gain insight about the role of automatic negative thoughts and maladaptive core beliefs on emotions and behaviors. CBT tends to follow this flow where a situation happens. It may also be labeled an activating event or a trigger, which prompts a thought. Now that thought is going to impact the person's emotion or mood, which then may impact their behavior or things they choose to do. Now, the wonderful part about CBT is when you work with patients and get them familiar with these concepts and get them to track their own situations or triggering events, their thoughts, that it helps them gain more insight on the domino effect, the cause and effect of certain actions or thoughts that may have led to a certain mood, depression, anxiety, anger, which then may have impacted a behavioral choice among which includes using a substance. It helps, and by doing that, I think it increases their insight and self-compassion, and sometimes as a byproduct decreases their stigma around taking medications, whether that's MAT medications or SSRIs and so forth. CBT also includes psychoeducation of addiction and the underlying neurobiology, which is very important for a similar reason. Teaching patients about what's going on in the brain can help them understand the part of things that are more in their control and the parts of their behaviors that may benefit from medications, at least in the beginning of their recovery. CBT also includes behavioral activation, fancy word for the notion that we tend to have less depression, more motivation when we're activating our behaviors, doing things. So helping patients who may not be working, develop a semi-structured routine for their day so they can get out and do things. And what we find is when people do one thing, they're more likely to be motivated and do some more things on their to-do list. And it's that kind of saying, the more we do, the more we want to do. And the less we do, the less we want to do. CBT also includes skill building, which I'm going to speak to on the next slide. But I also want to briefly summarize that in CBT, and part of increasing insight is helping patients notice when they may be having cognitive distortions. Fancy way of saying ways they may be misperceiving reality or distorting the truth, maybe overgeneralizing their experiences as all bad, catastrophizing little stressors, and in their mind making them larger. And so in this flow, it helps patients understand maybe certain unhelpful thinking styles that they may have used for years or decades in such a pattern and way that they're not even aware. It hasn't registered in conscious awareness, but they've been thinking a certain way for so long. So this can help break down those processes and help patients gain that insight. Okay. The skill building aspect of CBT involves problem-solving skills, which include organizational skills, planning skills, breaking down long-term goals into short-term goals, breaking down those short-term goals into action steps. The skill building can also include anger or stress management skills, things like learning deep breathing, positive imagery, also interpersonal and communication skills, learning about assertive communication and how to do that rather than passive communication, aggressive communication, or passive aggressive communication. That component also looks and helps patients learn how to have more healthy interpersonal boundaries or boundaries around other people. Oftentimes we found that people with addiction have codependency dynamics, fancy way of saying overly leaning on others to meet their individual needs or projecting their unresolved issues or emotions onto other people or absorbing too much of others' emotions. So we look at that. Also in terms of boundaries, we look at types of boundaries. You know, there's time boundaries, how much time you give to people or people expect of you. Material boundaries, how much do you lend stuff or ask for things. Sexual boundaries or physical space boundaries. Intellectual boundaries. So we really break it down for them. And I think this is incredibly important in addiction because oftentimes these things we're talking about, problem-solving skills, anger management, social skills, if persons don't know how to navigate them well, they can be huge triggers that can lead to cravings and use. And skill building is supported in the research. Clinical trials examining the addition of coping and communication skills training have demonstrated positive outcomes and are common components of CBT for substance abuse. Now, another component, psychotherapeutic intervention, is relapse prevention. I touched upon this earlier in substance use disorder counseling, but I want to unpack this a little more. What it entails is identifying internal and external triggers for use. So let me speak to that a little more. An internal trigger is either an emotional state or so forth that triggers a craving for that substance, and some sample internal triggers include loneliness, boredom, or being hungry or tired. So we have like an inventory of common internal triggers we have patients look through so they can familiarize themselves with what triggers me to have stress or negative thoughts that may increase my likelihood of picking up that opiate again. We also look at external triggers for use. These are things outside of ourselves that may trigger a craving and may include things like hanging out with people who used to use or still use, who still use, or driving by a certain liquor store where you may have picked up the substance or other substances and literally drawing a new route so you do not go near that liquor store. Or payday can be an external trigger for some people. And so we also have an inventory where we have people look at their external triggers and familiarize themselves with what triggers them. Part of relapse prevention also includes rehearsing coping more adaptively with triggers so they don't lead to cravings and or use. So now I've got that CBT model, but mapped onto a substance use disorder framework. And you see, instead of situation, we've labeled it trigger. The trigger is going to prompt certain thoughts, which may lead to a craving and may lead to use. We want to teach patients how to intervene at the trigger level. So one, try to avoid or decrease exposure to triggers, or intervene at the thought level, start to notice negative thoughts and manage them. A sample thought might be, I can't do this anymore, or I suck at this, or I'm never going to be able to do this. That's a random sampling there. But if we can help them manage the trigger and the thought, we can interrupt the cycle there and prevent the use. Because once a person gets to craving, that's a very powerful urge that can be navigated, but it takes more energy and work. Relapse prevention was most effective when applied to alcohol or polysubstance use disorders, combined with the adjunctive use of medication. So there's another reference underscoring the efficacy of relapse prevention in promoting the success of patients. I'd like to speak a little bit more to relapse. Relapse does not mean failure. Relapse is often a part of the recovery process. And when that happens, what we want to do is, one, re-engage our patients back into treatment as swiftly as possible with an empathic stance of almost unconditional positive regard. We want to unpack that relapse. We want to look at all the preceding events or triggers that may have led to that relapse, because it's very rare that a relapse happens overnight. Oftentimes, it's a sequence of events that have been building. We use the metaphor of relapse drift, that it doesn't happen overnight. Instead, it's like a ship that's slowly becoming untethered to shore, drifting into sea. And we want to help patients watch themselves as they're getting slowly untethered. For example, a patient may have relapsed, thinks and feels like it came out of nowhere, but we sit down and we look at the preceding time period and see, all right, maybe 3 weeks ago, they had a relationship breakup. And then they stopped working out, which was really important to them. And then they're watching a lot of news and they're reporting a lot of mass shootings. And then that patient starts to skip their meetings, and then a relapse follows. Maybe initially the patient feels like the relapse happened overnight, but as we unpack that time frame, we get to identify what happened and really be primed to focus on those red flag warnings for the next time. Oftentimes with relapse, there's feelings of shame, and that's something we want to work with in therapy, to translate shame into a moment of a lesson or an insight. And we help patients decipher between healthy guilt and toxic guilt. Healthy guilt serves us, and yes, guilt and shame are different, but both are felt often in relapse. Healthy guilt teaches a patient to pay attention to their intuition and follow their values. Toxic guilt is no longer useful. It's once the patient has applied the lesson, is moving forward, working their program. At this point, that guilt is no longer useful, and we label that toxic guilt. Okay. Now, another evidence-based treatment for opiate use disorder is motivational interviewing. I think this is one of the most powerful techniques. And if I would recommend any training to anyone, if you had to pick one, I would pick motivational interviewing. Now, research repeatedly shows the efficacy of this intervention. And ultimately, what it's designed to do is increase a patient's intrinsic motivation to abstain from opiates and resolve any ambivalency they may have about that goal. It involves expressing empathy through reflective listening, developing a discrepancy between the client's goals or values and their current behaviors. We want to use their language, their words, and work within that frame, because that's what's going to be most powerful to them. We want to avoid arguments and direct confrontation, because what we find is if a patient is not 100% committed to their recovery, they have some ambivalency. If we give them a more prescriptive approach, they'll tend to drift towards defending the reasons why it makes sense to use. So that's just psychologically what happens. So we avoid direct confrontation. We adjust to the client's resistance rather than opposing it directly. And we support self-efficacy and optimism. Okay. Another evidence-based approach for opiate use disorder is dialectical behavioral therapy, DBT, which was originally developed for the treatment of borderline personality disorder. However, the efficacy of this intervention has been found in the research for opiate use disorder. And it's got some wonderful skill building worksheets, components, a depth of information. The primary components include mindfulness, and it provides lots of fabulous techniques in which to practice mindfulness. And in summary, mindfulness is being present in the here and now. And it's a myth often that people think the goal of mindfulness and meditation is one way to practice mindfulness, but that the goal is to get rid of thoughts and feelings, which is not true. It's to be aware of them without letting them govern you. And so there's specific techniques that DBT provides that allows patients to practice this. DBT also includes distress tolerance or specific techniques to help patients tolerate waves of acute distress without jumping to use. And included in this are crisis survival skills. And I'll speak to one that's called TIPP skills, which recommend that in kind of an acute fight, flight, or freeze state or acute distress, you may apply cold temperature or ice to the temples, top of the head, back of the neck, which will instantly lower heart rate. The I stands for intense exercise. 10 to 20 minutes of intense cardio will discharge that adrenaline and cortisol in the bloodstream. And the P is for paced breathing and progressive muscle relaxation. Paced breathing is just learning deep breathing techniques, deep diaphragmatic breathing. And progressive muscle relaxation is a technique in which you take any muscle in the body or your fists and clench them really hard for 5 or 10 seconds and release for 5 or 10 seconds, which is another quick way to discharge that anxious or frantic energy to lower and kind of sedate ourselves naturally just a little bit so we don't turn and use. Another component of DBT is emotion regulation, and they provide great skills, sort of like CBT. It's a chain analysis of behavior, gives you charts to start to track what led to certain problematic behaviors, what was happening in the interim, so a patient can really understand themselves. DBT also includes interpersonal effectiveness skills, great worksheets and handouts on learning how to say no to other people, keep good boundaries, clarify your goal in any particular social situation. Group therapy is another evidence-based intervention for opiate use disorder. And the goals and benefits are it helps patients develop a sense of community. They get feedback and support from peers. They contribute to each other's recovery and reduces sense of isolation, which is huge because isolation tends to be a very powerful trigger for substance use. There's some theories out there also that depression is a hyper focus on the self. And by being in a group atmosphere or maybe a little bit going beyond this, getting someone involved in volunteer work or so forth, forces them to put their attention outward to others Others may be struggling with similar things or others in need. So it's a very, very powerful skill. With the pandemic, I know we've been quite limited, but there have been some wonderful Zoom groups in our community. And I hope we can continue to get through this pandemic and reopen in-person groups. The types of group therapy that are out there include family therapy, although I'll say it's rare to find this covered by certain insurances, although it's out there. There are support groups, which can be religious-based through local churches and other religious institutions. There's also Narcotics Anonymous, which I've mentioned, and MARA, the Medication Assisted Recovery Association. There's also process-oriented groups. These are groups that don't really have an agenda, but comment on other people's, others can comment on each other's kind of journeys, stressors, and recoveries. Process-oriented groups tend to work best in inpatient facilities or intensive outpatient facilities. There's also skill building and psychoeducational groups, of which relapse prevention is one. And at CEON, we host a weekly relapse prevention group via Zoom. And then dialectical behavioral therapy is often provided in a group format. And at CEON, we also provide a DBT group weekly. Anyone interested more in the MARA, which is new, the Medication Assisted Recovery Association, can visit mara-international.org. Website's very user-friendly, and there's one click away from saying join an online Zoom meeting, which is wonderful for our patients. There are quite a few in California, and again, they're all primarily via Zoom. I have had patients have success at local NA meetings. Although NA explicitly in their ideology do not have anything in writing against people on MAT, they tend to be run by local community members. So it's really up to the local community and the heads of that meeting what rules they want to put in place. So NA is an option for people on MAT. They just have to find the right meeting, the right fit for them. But luckily there's also MARA now. I want to speak briefly to barriers in getting people into group therapy. There can be overall resistance, a type of thinking, I don't need this. There can be co-occurring disorders that prevent the patient from being able to attend, such as anxiety or fear of being in groups with others. And some people generally feel uncomfortable. They struggle with being open, honest, or vulnerable around strangers, or they may have gender or sexual orientation issues. These barriers, it's important for us, or the case manager, or the substance use disorder counselor, or the psychologist or mental health clinician, to explore these barriers with patients, because the group aspect is a very powerful part of the recovery program. So we can explore these barriers in our work and give them tools to overcome them. Okay, just wanted to briefly note that the main differences between the 12-step philosophy of an NA and MARA is they don't mention God in MARA. Instead, they say whatever higher power, however you define. They also, instead of saying, and I'm not quoting this isn't a direct quote, but instead of saying that they're turning over all their power to a greater power, it's accepting that their power is limited. It's limited, and that they may benefit from the neurobiological interventions of medication. Okay, well, thank you so much for joining me, and I'm going to turn it over back to Amanda now.
Thank you, Dr. Bader, and thank you, Dr. Shaw. We're now going to go into Project Hope. Project Hope is a medication-assisted treatment program that CEON Clinical Corporation offers. And so I just wanted to share some information about that program with you guys today, and feel free to enter any questions that you have for Dr. Shaw or Dr. Bader in the chat box, in which they'll be able to follow up on those right after this part. So Project Hope, it's a medication-assisted treatment program, and it's to target the crisis rates of opioid use disorder amongst residents in Sonoma County, Lake County, Mendocino County, and Marin County. So we're an outpatient treatment program, and it's about a 90-day minimum program with a 3-month and a 6-month follow-up, as Dr. Bader mentioned in her presentation. So we serve about 100 adults annually over the course of a 3-year grant program. So Project Hope, what we offer are weekly physician visits for medication management, if that's what's necessary for that patient. Every patient is different, of course. Weekly individual and group counseling for the patients. Those services are actually free within our program. We do utilize telehealth services. So during the pandemic, we were able to remain open, offering telehealth services. Individualized treatment planning designed by a case manager and a counselor for each patient. We collect data amongst 4 data points, so a 3-month, 6-month, 12-month, and then graduation or discharge. So that's where Dr. Bader evaluates different aspects of their life and can use those data points to change treatment plans, see where they're doing better, see where they may need more counseling or not. We utilize 7 evidence-based practices, including motivational interviewing, stages of change, CBT, trauma-informed care, intensive case management, relapse prevention, and the 12-step facilitation therapy model. So throughout our program, we hope to increase the number of patients who are utilizing MAT services, which would decrease the number of illicit opioid drug use in the targeted areas that we want to cover within the program. And now I'm going to go ahead and turn it over to Dr. Shah and Dr. Bader for any questions that you guys might have. And we did open up the chat box, and we'll have a good interactive discussion where if you do want to enable your microphone, you can, and we'll go over each one that has come in so far.
Thank you, Amanda, Dr. Bader, for excellent presentation. We'll take questions now. If any of you want to unmute and maybe ask your question, sometimes it's easier to ask a question rather than typing your question in the chat box. Feel free to do it. Unmute your mic and ask questions if you, and we have, I think, few questions in the chat box. We'll start with that. And then we will take questions as it comes.
Dr. Shah, the first question is, what are some of the things to think about when evaluating if an induction is required or not?
That's a good question. And I think this question is related to, I think, buprenorphine treatment. So first of all, when you're using naltrexone or Vivitrol, you don't need a typical induction visit for those 2 treatment modalities. Basically for naltrexone or injection or which is Vivitrol or naltrexone tablet, patient have to be off opiate for 7 to 10 days, depending upon the type of opiates they are using. For typical induction, usually you need to do induction when somebody is actively using opiates. Somebody is actively using heroin, oxycodone, and any other, or Tylenol, PM, or any other opiates, agonist medications, and that's where you need an induction visit.
I saw, Amy, you opened your mic. Did you have a question? Okay, I'll go on to the next question. What does a withdrawal state look like?
I think the question here is referring to opiate withdrawal. The typical symptoms of opiate withdrawal are extreme anxiety, low mood. Sometimes there is some clinical depression that patient experience. The other typical features are GI disturbances where you see diarrhea, means your hairs are sort of um, prominent, and then there is also your pupils changes when you are withdrawing and you have a dilated pupils. So these are the typical symptoms of opiate withdrawal that you see. And then also you have increase in heartbeats, you have increased perspirations. These are also symptoms of opiate withdrawal, acute opiate withdrawal.
This is a three-part question. Can you go into more detail around how an induction happens?
Yes, certainly. Like I said, induction is usually done for those patients who are actively using opioid antagonist, short or long-acting medications, such as fentanyl, oxycodone, methadone, or heroin. And typically, depending upon the first stage of induction, or prior to even induction, is the psychiatric evaluation, where you take a detailed history of their condition, you do physical examinations, you inform patients about various treatment options, and then you schedule them for an induction. Now, prior to doing induction, you may want to run some labs like their liver function tests, urine analysis, CBC, and some of the basic data to see if they have hepatitis C or any other comorbid infections. And then you ask them to come for an induction, and if they are using long-acting opiates such as methadone, you typically ask them to refrain from using long-acting for about 96 hours. Sometimes I have asked patients to not use, depending upon the dose of methadone, up to 5 days. If they are using fentanyl, then you ask them to not use any fentanyl for at least 96 hours. And for those 4 or 5 days, you can give some medications such as clonidine, some trazodone for insomnia, some fentanyl for GI disturbances, so they are able to deal with withdrawal symptoms for those 4 or 5 days. And then you can also occasionally use few pills of benzodiazepine to help with the severe anxiety symptoms that they may have. Now, if somebody is using short-acting opiates, then they need to be off of opiates only for 24 hours. So you ask them to stop opiates for about 24 hours, and then you bring them into the office. Somebody has to drive them. You typically prescribe about 36 milligram buprenorphine to the day of induction to the pharmacy that they would be going. So the patient and the family member can pick up those prescriptions, bring it to your office. You do urine drug screen take, you take vitals, and then you give 4 milligram buprenorphine first, and then you look at their cow scale before giving buprenorphine, and then you periodically monitor their cow scale every half an hour to an hour, and then you keep giving them 4 milligram dose until you see that most of the withdrawal symptoms are gone and their cow scale is stable. And then the next day you bring them again, and then you assess them for withdrawal symptoms, or if you see them over-medicated, then you try to adjust their dose, and likewise you bring them at least 3 days. And then once somebody is on a stable dose, then you see them once a month on buprenorphine ongoing prescriptions.
You kind of answered the second part, and the third part is, how do you know once a good dose for that patient has been reached during supervised?
I think by day 3 or day 4 you will know. So you assess for 3 things: whether the patient has withdrawal symptoms, You assess the second thing, whether they have been over-medicated or if they are showing sign of cognitive slowing, excessive sedations, or any other problems along those lines. Third thing, you will look for craving. If patients report that they no longer have cravings for opiate, that's also a good sign. And that's where you see that the appropriate dose has been achieved. And then you use, and usually the maximum dose, like I said in my presentation, that is 32 to 36 milligram maximum. And I have rarely gone to that dose. Most of my patients do well with 12 milligram to 24 milligram dose after induction visits and so forth. So you look for craving, look for what their mental status is and how they are cognitively doing on medication. And the third thing you look at is what their withdrawal status is. Once you satisfy those three clinical parameter, and then you know that you have a appropriate dose for that patient.
This question is for both Dr. Bader and Dr. Shah. How do you prevent splitting amongst the medication-assisted treatment provider team? Is this common in this population being treated?
This is an excellent question, I must say, that we see it all the time, especially you have a multi-specialty program, and then you have a biological provider who does medications, and then also psychotherapists and counselors who provides counseling. I think the most important part is everyone in the treatment program must know what their program looks like. They all must be educated about what the program looks like, what the different part of the treatment looks like, what biologists do, what the psychotherapy. So everyone's role is very well defined. The third thing is the patient's pathology must be assessed. So you look for their comorbidity on axis 1, like depression, or what they may look like on axis 2 in terms of personality disorder. And the third part after that assessment is you periodically meet in a clinical meeting and discuss your cases. You exchange your perspective about how you see patients and then try to understand the other team members' perspective. So that those are the three very important parameters for avoiding any splitting, And I also have maybe Dr. Badare share her experience and viewpoint, because this is probably her territory,
Dr. Shah did a great job, and I'll just reiterate the importance that the whole treatment team is very familiar with the program policy and program rules. And then if we are presented with such information in session that we don't jump to react, we can hold that and bring it to our treatment consultation meetings and kind of problem solve together and know what message we're going to tell the patient and be consistent in the message we give them. So we're saying the same thing. So thank you.
And I want to just reiterate one more time that if anybody wants to speak and ask questions, feel free to do that. You can just simply unmute your mic and ask your question. Okay, we don't have any more question. I think that's it for today then. Okay.
Thank you, Dr. Shah.
Thank you.
Thank you, Dr. Bader. We will go ahead and leave the PowerPoint up for just a few moments. If you are here for CME or CE credit, I believe everybody did sign in the chat box, so great job doing that. We will reach out with a evaluation form for each of those, and then what you'll do is complete the evaluation form and then return the form to me, and then I'll send you a certificate of completion where you'll be able to self-report for those credits. Okay, so I'll go ahead and leave the PowerPoint up for just a moment longer, and then if any questions do perhaps come in, we'll go over them as they come in, but we'll stay open until 6:30. Thank you, everybody, and have a good evening if you're logging off.